Welkom bij de Nieuwe Wereld, verdiepende gesprekken in een tijd van verandering. Ik ben Jona Walk en vandaag is bij mij te gast professor Christine Stabell Benn, oorspronkelijk opgeleid als arts, nu hoogleraar Global Health aan de University of Southern Denmark, die haar carrière wijde aan het onderzoeken van de algemene effecten van vaccins op ons afweersysteem en daar nog altijd erg druk mee bezig is en veel onderzoek doet, met name in Afrika. Welcome, Christine. Thank you so much for joining us.
Thank you very much.
So, we of course know each other quite well from when I was a PhD student. I had the great honor of working with you a little bit for part of my research. Learned a lot, but the audience will not yet know you. So I thought I'd like to introduce you by sharing very briefly the first time I think that we had a one-on-one conversation. It was in Cambridge, and we'd been at we were at the scientific meeting about vaccine research. And I was just a beginning PhD student, and we found ourselves in this pub waiting for the rest of a group to come, and we were having a beer. And I was sitting there as like this beginning PhD student, like, oh wow, this is that professor that I look up to so much. And I remember telling you that I'd read one of your papers about the positive and negative effects of specific vaccines. And I remember telling you that I had presented the paper to my research group in IMEG, and that you responded by saying, oh, so how did you react to that? What did they think of the paper? And I was wondering if maybe you could tell the audience that doesn't yet know you that well a little bit about what your research is focused on, and why it is maybe a little controversial.
Yeah, thank you for that anecdote. I'd forgotten about that beer in the pub, but I definitely hadn't forgotten about you, because I get so happy every time I meet a young researcher who's interested in this field of non-specific effects of vaccines that has been on my mind for the last 30-some years now. Our research is looking at vaccines, but not from the traditional understanding that a vaccine is just something that creates specific antibody and immune response and specific memory towards the vaccine disease that you are vaccinating against, but from the perspective that vaccines can also more generally affect the immune system. And this is a new discovery and still quite controversial. So I think that was the reason why I asked you how your audience received your presentation, because among a lot of doctors and other health staff, health personnel who were trained in the traditional understanding of vaccines, it can still be considered rather controversial when somebody suggests that vaccines can also affect the immune system more broadly. In other terms, it's going against the general thinking about vaccines, and as such can be seen as provoking. But I would be happy to elaborate a little bit more, because I know this can sound rather cryptic, and tell you more about how these findings were initially made, and what we have about the general pattern that we have observed. Because basically this whole research agenda starts the systematic inquiry into vaccines and their broader effects. It starts before I entered the field. It starts back in the 1980s with my mentor, Peter Abi, who was studying the production of measles vaccine in Africa, and that led to a very surprising discovery. I can see you were breaking. You wanted to ask me something maybe before I continue?
No, I think this is a very good. So the audience, of course, is not immunologists. There are people who are very interested in the topic but don't have a background in this subject. So I think indeed maybe telling the story of how you first got on the trail of this finding, and how different how it developed into a real new research field and a new way of looking at the science is a very good way. So I'd love to hear your version of that.
Yes. So it all starts in the beginning of the 1980s when Peter Abi is working in Africa, trying to understand the reasons for the high child mortality, and as a part of a study as a service to the community. His team gives measles vaccine to all children in the community who are at home at that given period where measles vaccine is distributed, whereas other children didn't get the measles vaccine. And then after a year, he does the numbers, so to speak. He counts for who survived, who died in the meantime. And what comes out of this is this surprising observation that measles vaccine has reduced mortality in the group that received it by 70%. And that is astonishing because measles were only around maybe 10, maximum 15% of all deaths at the time. So the introduction of measles vaccine should not have reduced mortality that much. And by the way, the control children, the children that didn't receive measles vaccine, it wasn't that they died in high numbers from measles. So this suggested to Peter there was something very strange going on. How could the introduction of a vaccine in a community where measles vaccine at that time wasn't used, how could the introduction of this vaccine then suddenly, over 1 year, decrease mortality that much? And Peter then spent around 10 years pursuing the hypothesis that perhaps measles killed not only in the acute phase, but also was associated with long-term mortality. And by preventing measles, he would not only prevent acute measles death, but also long-term death from measles infection. But he was able to refute that hypothesis. And the only remaining possible explanation would be that measles vaccine was associated with some benefits which were beyond just the mere protection of measles infection. And in the meantime, also, he had repeated this observation in 4 different other countries in the world that had data on mortality before and after the introduction of measles vaccine. And in all the total of 5 studies, the introduction of measles vaccine was associated with at least a 50% reduction in all-cause child mortality. So he was pretty certain that this finding was correct, and he was also pretty certain that this had nothing to do with the prevention of measles infection in itself. So what remained was this observation that measles vaccine seemed to confer some additional benefits. And this clearly contradicted the textbooks, as I said, because measles vaccine, according to the current understanding of vaccines, should only protect against measles infection and nothing else. Peter wrote a paper about this in 1985 in the British Medical Journal and coined for the first time these effects, non-specific effects. So the effects of the vaccine that go beyond the specific protection against the vaccine disease. So this clearly spurred an interest into understanding if other vaccines could have similar effects, which would make them even more beneficial than one would think. At least in the case of measles vaccine, this suggested that measles vaccine could be used not only as a vaccine against measles, but potentially also as a general immune boosting vaccine. So he went on, and there I joined the team also. We went on to study systematically all the childhood vaccines that were being used in Africa. And what we observed was that all of these vaccines had unexpected, non-specific effects. And
What at the time?
So in total now we have studied 10 vaccines. We have studied 4 live vaccines, which are the vaccines that contain the disease organism in a weakened form. And these vaccines give a very mild infection in the body. It's usually so mild that you don't get any symptoms when you get the vaccine. But it's a vaccine that resembles very much the natural disease, just in a very mild version. And they are known to give a very broad immunity. So usually one vaccine is enough to create lifelong immunity. They're, in that sense, very good and strong vaccines, but they also have the small caveat that they can, on very rare circumstances, create the real disease, particularly, or if the one that receives them is somebody who has a very weak immune system. And there we're not just talking about, I get a cold very often, but people who are born with gross errors in their immune system or who have AIDS, for instance, so very severely immunocompromised people. But anyway, all these live vaccines we studied, and that's the measles vaccine, both in an isolated measles vaccine and in the combination with mumps and rubella vaccine, the MMR vaccine, and the oral polio vaccine, and the smallpox vaccine, which has now been stopped, but was used all over the world to eradicate smallpox, and then the BCG vaccine against tuberculosis. All these 4 vaccines have been associated with very strong reductions in all-cause child mortality, which are much stronger than we can explain based on the prevention of the diseases that they are designed against.
The sort of classic vaccines, what we think of, that's very close to the natural infection, of course, slightly less disease causing, and they seem to confer these positive effects. And then did you go on to study this in other types of vaccines? Because the very few vaccines that are still developed are like this, are these traditional style weakened diseases.
Yes, so there are many more vaccines, as you say, now being developed that are non-live vaccines, and that's among others because, as I mentioned, there is this caveat with the live vaccines that one is always a little afraid that they can cause the real disease. So there's this tiny but of course relevant risk that they can cause the real disease in people who are compromised severely. And also the live vaccines are a little bit more difficult to produce, generally speaking. It's a little bit like baking sourdough bread. I usually say, that anybody who has tried to do that knows that there will be days where you really don't understand why, but the temperature, the humidity, something is changed in the air and the bread doesn't become as nice and airy as you would like it to be. There are more challenges to growing these live vaccines, and they also need to be kept on a cold chain. So logistically, getting them out in Africa, for instance, can be a challenge because they have to be kept cold. And also they often have to be discarded once they have been diluted and reconstituted for use. So many producers are now looking towards non-live vaccines, and more and more of the new vaccines are non-live. Though I should say that already some of the first vaccines were also non-live. There are things that can be impossible to design live vaccines against. But anyway, the non-live vaccine, and here comes the troubling part of our findings, and perhaps the main reason why they are still seen as controversial by many people, is that the non-live vaccines that we have studied have been protective against the vaccine disease, as they are when you have received some doses. But they have also been associated with negative non-specific effects. So that means that this is particularly seen in females. So that means that what the general pattern we have seen is that females who receive these non-live vaccines actually, despite being protected against the vaccine diseases, have higher overall mortality.
How did you see that? How did you discover that in your study population?
So the first study where we saw a signal of negative effect was in this systematic evaluation that I said we started after seeing the beneficial non-specific effect of measles vaccine. And in this particular study, we went out and looked at the data from the rural areas in Guinea-Bissau, where we have our field station in West Africa. And we looked at the vaccination status of the children we visited every 6 months. And saw that whether children had received at that time of the visit either the BCG vaccine against tuberculosis, which is recommended at birth, and or the diphtheria tetanus pertussis vaccine, a non-live vaccine, which is recommended around 1, 2, and 3 months of age in low-income settings. So we observed the vaccination status of the children at the primary visit, whether they had BCG or this DTP, as we call it, vaccine, diphtheria tetanus pertussis vaccine, or both. And then we came back 6 months later and registered what had happened in terms of all-cause mortality with the children. And what we saw was that the group that had the highest mortality in the period between the 2 visits were the children who had received no vaccines. at our first visit. So that was reassuring that in that sense, not receiving any vaccines were the worst. But then there was a much lower mortality among those children who received BCG vaccine alone. So these children had almost a halving of their risk of dying. And to some extent, this could have been explained by the fact that healthy children are, generally speaking, vaccinated earlier than unhealthy children, because anywhere in the world, parents are reluctant to vaccinate those children. So we know that there is this healthy vaccine bias in any comparison between vaccinated and completely unvaccinated children. All the biases we know will favor the vaccinated children and make them look healthier because they were healthier from the beginning. It was not due to the vaccine per se necessarily, but they were healthier from the beginning. But these 50% reduction was, of course, a very strong reduction in all-cause mortality, which is hard to understand from the perspective that these children should just have been a little healthier from the beginning. And what was really striking was that the children who had received both BCG and DTP vaccine, for whom the biases would have really, the biases should really work in favor of those who had received both vaccines, we saw that their mortality was almost as low or as high. Their survival was almost as low as those who had received no vaccines. So that meant when we analyzed this in a survival analysis, what came out was this almost 50% reduction in the risk of dying associated with receiving BCG alone. But there was almost twofold higher risk of dying if you had received HPV vaccine and BCG vaccine. And this was isolated to the DTP vaccine effect because it contrasted the BCG vaccine effect. So we went to WHO at that time, and this was in 2000, and said, we have this paper in pipeline, we haven't submitted it, or we haven't published it yet, but we have these troubling observations that suggest that at the same time, two different vaccines, BCG on one hand and the non-live DTP vaccine on the other hand, can have completely different effect on overall mortality, suggesting that there might be positive beneficial effect of BCG and negative non-specific effects of DTP vaccine. And to cut a long story short, there were many attempts to get this paper stopped from being published, but it was eventually published in BMJ in 2000. And WHO went on to send a mission to Guinea-Bissau to try to understand what had been going on. The mission came to Guinea-Bissau, clearly hoping to find some error that could explain the finding, but they didn't identify the error or any error. And they went back to the WHO that then initiated an investigation into the negative non-specific effects of DTP vaccine. And here comes a very long story, maybe that's hard to cut short, but the WHO commissioned a number of sites to do the studies. We were cut out of the process, which was a pity because we had made a lot of experiences trying the initial analysis that told us a lot about the pitfalls in the statistical analysis of this data. That wasn't really taken into account, so it initially came a series of papers out of this inquiry at WHO that all showed extremely beneficial effects of DTP vaccine. But this was because they had what is called survival bias, and that was later acknowledged. So in the first place, WHO dismissed the findings. In the next place, in 2008, they said they would keep a watch out for these non-specific effects of DTP vaccine. And in 2013, they eventually went on to do a review, and that review was a BCG vaccine, measles vaccine, and DTP vaccine, and came out with a quite strong observation that both BCG and measles vaccine were associated with strong benefits on child survival in the range of a 50% reduction in child mortality. But DTP vaccine was associated with a 38% increase in mortality. And that is basically where we are now. WHO recommended to have more studies done in this and also delegated it to a subcommittee, but that committee hasn't done anything about it. And that's now 10 years down the line where we are still waiting for that thorough investigation. And meanwhile, we have been producing more papers, and we now have a total of around a dozen of papers that show negative non-specific effects of DTP vaccine, particularly for the females. And even more papers showing that for other non-live vaccines, there are also these same negative non-specific effects for females. It is pretty crazy because it's of course super worrying that something that is given to billions of children all over the world can be associated with negative effects on overall survival, even though it protects against the vaccine diseases. And it's troubling that there doesn't seem to be an adult in the room, so to speak. There's nobody who's taking responsibility for that danger signal and conducting a thorough investigation.
Yeah, that's troubling because I'm afraid I've kind of course, experienced this as well. And we'll get to talking about COVID vaccines in a little bit, but I have a couple more things that I'd love to talk about on this topic. But I've also noticed that when you have scientific, we all talk about medical science as this great, unbiased techniques that, you know, we've perfected. The system that we have now works so well. But I've also noticed that when you have scientific data that has the potential to have implications that people find problematic, either because they go against something that's considered dogma, or because there's financial interest involved, or people get very worried, that there's a tendency to at least for a long time consider, it's probably not true, and to put much higher demands on the researchers than a story or a scientific study that fits very neatly into the narrative that we'd like to have it. I'm wondering what your experience has been, where you think, why does this happen? Why are we so vulnerable to that kind of bias in the medical scientific world?
I wish I had a short answer for that one, or any answer. I don't know. Ideally, this is not how it should be, but clearly we are all affected by this type of bias that we like to hear, and we don't question as much the new results that corroborate what we already knew, or confirms our ideas, as we are to the research that contradict it. I don't think anybody can say that they are not subject to this confirmation bias, as it's called. I think our biggest task is really to try to create awareness about it also in ourselves, and scrutinize all data the same way, whether or not it confirms our beliefs. But clearly this is not easy, and clearly it is not happening when we talk about vaccines. And I think it has to do specifically for vaccines with the fact that textbooks have been ignoring that vaccines could affect other diseases. And it's not because it's ever been investigated, but it's because the belief that the immune system is so simplistic that it only responds with antibodies, and the immune response to one specific vaccine disease when it's vaccinated is so engraved. So it seems it hasn't seemed ever necessary to investigate vaccines for their broader immune effects. So the textbook says one thing, and then comes on top the fact that vaccines are a great invention, and clearly the smallpox was a super dangerous and deadly disease that left a lot of people either dead or full of scars in their face and all over their body. And having a vaccine, developing a vaccine against this disease and actually being able to eradicate it completely is one of, if not the greatest success of medicine ever. But that has created an understanding that vaccines as such, as an entity, are medicine's greatest tool, and it's not supposed to be questioned, in combination with the fact that we also have an anti-vax movement that has created a very unhealthy environment in the medical profession, I think, where there's a particular bias against any result that suggests something negative about a vaccine.
Yeah, and that's of course problematic, considering how we're trying to quite quickly develop all sorts of new vaccines. And I applaud that effort. If you can save lives with a vaccine, that's fantastic. I, of course, like you, spent a lot of my time working in vaccine research. But it is important that you don't lose sight of the ability to actually honestly evaluate and honestly discuss, hey, is this actually giving an overall benefit? So maybe very quickly before we move on, would you say something about how this works? So you said traditionally we think of you give a vaccine. This is also if it's explained on TV or anywhere. They tell you you take this vaccine, your body makes antibodies, you can't get sick from this virus that's coming. But we both know that looking at the immune system in that way is far too simple. Maybe, if possible, for a public that's not has no background in immunology, could you very quickly explain how you should look at the immune system in the context of what you found with these non-specific effects of vaccines on different diseases?
Yeah, so we were super happy that the group you work with at Nijmegen was pioneers in explaining and also showing how the innate immune system, which is a part of the immune system that has been ignored for centuries among medical doctors, how that innate immune system can actually have be trained by infections and vaccines in a manner that alters how you respond to everything afterwards. Because we had been producing our findings, and I think I forgot to say, or I didn't mention that, we found these beneficial non-specific effects of the 4 live vaccines, measles-containing vaccines, the oral polio vaccine, smallpox vaccine, and the BCG vaccine against tuberculosis. But we found these negative non-specific effects of the DTP vaccine, but in addition, also 5 other non-live vaccines, namely the pentavalent vaccine, the H1N1 influenza vaccine, the new malaria vaccine, RTSS, the hepatitis B vaccine, and the inactivated polio vaccine. So a total of 10 vaccines, 4 live, 6 non-live, with very consistent patterns of benefits of the live vaccines, harmful effects for females of the non-live vaccines. We saw this again and again in the epidemiological studies, but one of the critical points for people reading these studies were, this is biologically implausible. How could a vaccine affect the risk of dying from other infections? This is not possible. We know it affects the B cells, the T cells, but how could it have broader effects? And there came the findings from Nijmegen, like a beautiful revelation of, yes, your group could show mechanistically, you showed it also in actual human beings, that it happened within their body, that once they received the BCG vaccine and later were challenged with malaria infection, then they responded differently to the malaria infection if they had received the BCG vaccine. So you have shown, your group has demonstrated how a vaccine can actually, through effects on this innate immune system, affect in a manner that nobody had foreseen also the risk of other completely unrelated infections.
Actually, summarized, yeah, it's something I've been saying also on this channel and in many things in the context of the COVID discussion. It's a nice bridge to that topic, maybe, that the immune system is an incredibly complex organism that's different in every individual, not only based on what genes you have, but also on everything that you've encountered in your life, leaves a lasting change to the immune system and all those different. It is ridiculous to think that a vaccine would or a disease would affect only a tiny part of your immune system, like the antibodies, but all those other cells and other components of the immune system also have some effect, and that can either help teach them to fight other infections better, or it can give protection to one disease at the cost of protection against other diseases.
And that exactly, maybe I would just add that your group showed that the live vaccines indeed train the immune system beneficially, but the flip side of that is that sometimes the immune system can also be untrained or be what we call tolerized. And in this sense, we don't think of tolerance as something positive, because that means that the innate immune system will respond more lazy to challenges. And indeed, what your group shows is that the non-live vaccines that we have studied epidemiologically, that they also immunologically are associated with making the innate immune system more lazy. So really the two types of studies, the epidemiological studies that we have done and the immunological studies that you have done, they all tell the same story, that you can affect the immune system, the innate immune system, as you say, not only in ways that make it stronger, but also in ways that sometimes make it more, for some vaccine types, make it more lazy.
Yeah, and of course, the flip side of that is that the effects of that are also complicated with effects not only on infections, but we are now learning even on other diseases as well, which I think we will save that for another day. I did want to talk a little bit about COVID vaccines because it's for some people that's over, that's in the past, but for a lot of people it's not. I think for me, and I think for you as well, we're still trying to understand them. So you found that the classic vaccines, in the sense of weakened diseases, they confer sort of these broad positive effects for your immune system, and that the other also classic type of vaccine, where you just have a little piece of a disease combined with some chemicals or things that as adjuvant to stimulate the immune response, that those generally seem to confer sort of negative effects, broader effects for your immune system. What about COVID vaccines? What about mRNA vaccines?
Yeah, so we were actually really excited about these two new vaccine platforms, but rather agnostic in terms of what kind of non-specific effects they might have, because both the mRNA vaccines and the adeno-vector vaccines, which were the AstraZeneca vaccines and the Johnson & Johnson vaccines, were new vaccines. And I was pretty open to the idea that both of them might actually work as live vaccines, because they have a different way of working on the immune system, which isn't entirely non-live, but at the same time maybe wasn't entirely live, so to speak. So I really hoped, but I knew that was in vain, that the phase 3 trials would have a focus on also overall morbidity and mortality, and not just on COVID-19, because I thought with the knowledge we now have about vaccines and their non-specific effects, the current framework for testing vaccines is simply not enough. We cannot just study the vaccine disease and those adverse events. We need to ask every study participant about all their diseases, all their infections, and nothing can in principle be seen as irrelevant or not caused by the vaccine. Anyway, the phase 3 trials didn't study non-specific effects. And I also tried to advocate that when the vaccines were rolled out, we should do it in a manner in the phase 4 trials or in phase 4 trials where we could actually compare vaccinated and unvaccinated in an unbiased manner to create estimates of their effect on overall health. So we would know more about whether the newer vaccine types had non-specific effects. But that also wasn't happening, because the way the system for testing and approving vaccines is designed, it's really only with a focus on specific effects and then these potential plausible adverse events. So we took it on our own shoulders to do the best we could do with our abilities and with the available data. And that was to go back to the phase 3 trials that were published in the literature, and also go back to the reports that were sent into the authorities, to FDA and to EMA, and look for each of these phase 3 trials of the new vaccine types, the mRNA vaccines and the adeno-vector vaccines, for all the people who died within the trials of any cause, with the idea to study whether there was an anticipated reduction in all-cause mortality in the vaccinated subject versus the unvaccinated subject, because the trials had shown that the vaccine protected against COVID and should hopefully also be associated with reductions in all-cause mortality. But what turned out to be the case was that the two vaccine types had very different effect on all-cause mortality. So this we published last year. We compared in the phase 3 trials, within the mRNA trials, all who died in the vaccinated versus the placebo group. And we found that there was a 60% reduction in the risk of dying from COVID-19 among the mRNA vaccinated participants. This was not statistically significant. There were too few deaths for that, but it was in the anticipated direction that the vaccine protecting against COVID-19 also protected against death from COVID-19. But this was counterbalanced by an increased risk of dying from other causes. So in total, there was no mortality benefit overall of getting mRNA vaccines. And there were quite broad confidence interval, which means, in other words, that there was still room for within this data that the mRNA vaccines could be associated with quite substantial benefits in terms of all-cause mortality. But there was also the worrying possibility that they might actually be associated with increased overall mortality. And the big problem was, of course, that numbers were so small, so it wasn't really possible to say anything very firmly about the effect on overall mortality. And we were criticized quite a lot for pooling the data this way and presenting them this way, because a lot of people got upset about it and said, oh, but you cannot just, these studies weren't designed to study overall mortality, so you cannot just combine all the studies and conclude something about overall mortality. But our reply was all along, yeah, we also agree that numbers are small, but this is the best we can do. And the overriding problem is that we have such small data. We are giving these vaccines to billions of people, and we don't have good data that show that this is associated with overall benefits.
That argument a lot of times, and there's some merit to it, of course, that you're trying to conclude something on a study that was way too small to draw those conclusions, but then the burden of proof should be on the people implementing the vaccine to prove first that it has a beneficial overall effect. And clearly that wasn't there based on the phase 3 studies. And it's crazy that you get those responses, because you've always been very, very careful in formulating these discussions and acknowledging where the limitations are of the research that you're trying to do. So based on the phase 3 studies, you concluded that you can't for sure say whether there's any negative effect, but you also can't for sure say that there's a positive effect. What should have been the next step if you had been in charge?
Yeah, so obviously I think this, I wrote an op-ed in Denmark with some researchers here suggesting how the vaccine should have been rolled out, because there were several ways to roll them out to the population. And I know there was a high demand for them. Obviously, we were in a very problematic situation. So I can see why it would have been unethical to delay vaccination of people who were in high risk of dying from COVID-19. And there we are talking about people who are perhaps over 60 or over 70 or 80. I mean, where mortality really started to become high when they were infected for the first time with COVID-19. But still within that group, we could have done a random, and that was what we proposed. We could have done a randomization to early versus later vaccination, to the actual vaccination time point, because we couldn't, of course, vaccinate everybody on the very same day. So we could have utilized that period to make it random who got vaccinated in which order, which would have allowed us to actually also in this very vulnerable group to detect if the vaccine was associated with immediate death. And there were some speculation. There were also some signals from Norway that led them to stop vaccination of the most vulnerable people, etc. So I think that would have been useful under all circumstances. You could have given the vaccine and without delaying the overall date when everybody in the risk group had been vaccinated, but just by making it random in which order people got it. So that was one of our suggestions. The other was that once the high-risk group had been vaccinated, we found it justified to randomize people who wanted to be vaccinated to get it earlier or later, to create this window of opportunity to compare those vaccinated with those unvaccinated in great enough numbers to actually be able to conclude whether the vaccines had overall benefits that we wanted them to have. But as I said, the framework for testing vaccines is simply not set up to that, and everybody within the regulatory system that handles this are still, I think, convinced that vaccines only have these effects on the vaccine disease. And then perhaps in the first days, 2 weeks after vaccination, you can have a sore arm or a headache or some fatigue or a little fever. But these are the things that are looked for. And if they aren't found in great numbers, and even if they are found in great numbers, the usual conclusion is, yeah, well, it's normal you get a little ill after vaccine, but look at all the benefits you get, so you shouldn't worry too much about that. So obviously this testing wasn't done well enough, and that leaves us with a great problem in hindsight that they haven't been tested good enough. And now when everybody was vaccinated in this manner, it's really hard to conclude anything. We're still left 3 years down the line without actually knowing the overall health effects of mRNA vaccines. I would like to also say that we did exactly the same investigation for the adenovirus vaccines for AstraZeneca and Johnson & Johnson, and there we saw actually both strong, significant reductions in COVID death, but we also saw a strong, significant reduction in the risk of dying from other diseases in the phase 3 trials. So this to us suggests that the adenovirus vaccines, which are actually built on a live adenovirus, do behave like the other live vaccines that we have studied and has potentially beneficial non-specific effects, which is a bit ironical because these vaccines were stopped in many countries because of the risk of serious adverse events in the form of VITT, this coagulation disorder, but it was perhaps the wrong vaccine we stopped in the sense that had we looked at overall mortality, these very rare serious adverse events would have been counterbalanced from what we can see in the data from beneficial non-specific effects that would have made the recipients more able to survive than those who didn't receive the vaccine. But the very interesting thing is, here numbers were bigger, we reached statistically significant results, but the effect of mRNA vaccines on one hand and the adenovirus vector vaccines on the other hand was completely statistically significantly different. So this really suggests that the two vaccine platforms are very strongly different in terms of their overall health effects. And I think that is extremely important given that there are now so many new mRNA vaccines being developed for no matter which disease. So we really need to find out as quickly as possible whether the vaccines are associated with overall benefits. And as I said, it's going to be difficult for the COVID mRNA vaccines, but I hope that these results will make it imperative to test, for instance, a new influenza mRNA vaccine or RSV mRNA vaccine or whichever type of mRNA vaccine for their overall health effects.
You hit the nail on the head. I think what a lot of people who are sort of in the vaccine field, but maybe are not as deep in the vaccine field as say you are, when they think too simply about these vaccines, like you've said. When I shared a piece that you wrote on LinkedIn, I got a comment actually from one of the major policy advisors in the Netherlands who argued the loudest for giving COVID vaccines to children, saying, well, yeah, but this what you're talking about, it's not possible, it can't be done. So I wanted to thank you for very clearly explaining how this could very easily be done in practice, because I think what you're proposing is something that is definitely possible and should maybe even become part of how we look at vaccines. I actually wrote a similar piece with a colleague in the Netherlands, Bert Mulder, who is a microbiologist, and we wrote a piece in January of 2021 with a similar message, how we could safely implement these vaccines and gather the data that we need. Because I think what people, many medical doctors and researchers forget is that the nature of these non-specific effects are so variable that you don't necessarily notice it if you don't look for them. I think one of the reasons that the AstraZeneca and the Janssen vaccines that caused what you talked about, the VITT. So for viewers, that's the vaccines that caused the coagulation problems, the blood clot problems. That was a very specific disease that we had never seen before. And so it's very easy to pick out. But non-specific effects of vaccines can present simply as, getting slightly more risk of pneumonia, of other infections. So you wouldn't necessarily see them unless you look for them. And that makes it so important that we actually look for it. So I wanted to go talk ask you a little bit about what's sort of the status quo. What are you working on now with regards to these non-specific effects of mRNA vaccines? What do we have to look forward to in the future?
So we just published a preprint where we did for the child phase 3 trials exactly the same as we did in the adult studies. So I explained how we looked for the phase 3 trials and counted all the deaths in both the vaccinated and in the placebo recipients in the phase 3 trials in the adults of mRNA vaccines and of adenovirus vector vaccines. On the other hand, for the children, only mRNA vaccines were tested in phase 3 trials. And there we wanted to do the same thing. So we looked in all the published papers, we looked in all the many thousand pages reports submitted to the FDA and EMA to collect all the data on overall mortality and morbidity in these phase 3 trials. Fortunately, there were no deaths. The trials were rather small and of a rather short duration. So this was, it would have been very unfortunate if any child had died. And as I said, fortunately, nobody did. But we looked also at the risk of getting other infections during the follow-up period. And these were actually recorded in the child studies and reported in the child studies. This was done in tables in these many thousands of pages of reports. And we had to dig very long and very hard to find these tables and tease out the numbers. But we did that and compared for the recipients of mRNA vaccines with the recipients of placebo, what was the risk of getting both serious and severe adverse events as part of the normal reporting of vaccines, but also the risk of getting other infections. And it was particularly interesting to us as researchers into non-specific effects to note that there was a threefold significantly higher risk of getting a lower respiratory tract infection in the mRNA vaccine recipient children versus the placebo recipients. And this was due, among others, to an independently significantly increased risk for getting the RSV infection in the vaccinated children. So to us, this suggests, together with the adult study that we did, that the mRNA vaccines may have negative non-specific effects. And there we also then support from immunological studies. So among others, the group in Nijmegen that you were a member of, they have looked at the mRNA vaccines in adults, comparing their innate immune responses after versus before they received mRNA vaccine. And they published recently that the innate immune system became more lazy after the mRNA vaccines, just as we have seen for other non-live vaccines. And an Australian group looked the same way in children and found exactly the same results. So up to 6 months after receiving mRNA vaccines, the innate immune system is more lazy, and particularly when you challenge it, you take the cells from the innate immune system and you challenge it with virus or something that looks like a virus, the innate immune cells don't respond as much as they did before you got the mRNA vaccine. So again, the epidemiological studies and the immunological studies support each other and corroborate these patterns that we have seen for other vaccines and for other non-live vaccines, that the mRNA vaccines are associated with a higher risk of getting other infections in a period after vaccination. And this is due to its effect on the innate immune system that becomes less vigorous when it's challenged. So there are many reasons why we suddenly have RSV outbreaks on unexpected times of the year, why I think many parents complain that their children are ill all the time. And part of that is clearly the lockdown and the immune depth that created. But I think the really worrying observation is that we cannot exclude that this can be due to mRNA COVID vaccine. And again, this is of course particularly worrying given that we are now developing new vaccines on this mRNA platforms in large numbers, and we're getting as a world to rule out the worrying possibility that this could impair our immune system's ability to handle other challenges.
Yeah, because if I look at the total body of data, there are, of course, other studies that seem to show stronger activation of innate immune responses after COVID vaccinations. But I think that those were done with methods that are not as well tested and not as good as the methods that the group in Nijmegen used. But of course, your analysis of the clinical trial, which shows with statistical significance, children who get the COVID vaccine have lower chance of COVID, but a higher chance of these other lung infections. Yeah, that's very strong evidence, and that to me warrants absolute further research. And it is crazy to me that not every group in the vaccine world is immediately researching this. So maybe to begin to round off our discussion, so I don't take up too much of your time, I was wondering if maybe you wanted to share a little bit about what your experience has been sort of during the COVID pandemic and now talking about these very sensitive, very controversial issues, and how you think that has been perceived by a wider public, how we handle talking about these COVID vaccines as a scientific community.
So I was in the habit of communicating about vaccines and programmatic findings before COVID, because we have all these observations of non-specific effects that I've tried to, for a long time actually, I was sitting on my hands and didn't talk much about it in public because I feared potential pushbacks. But as we were, I think it was around 2018 where we had the WHO review. It's published in BMJ in 2016. It's strongly supportive of non-specific effects, but yet WHO hadn't responded. I thought I will enter the public domain and start talking about this. I need to do that because otherwise I will feel, I think I'll end up feeling very guilty for not sharing this knowledge and shouting up that there is a problem that needs to be dealt with, since, as I said, it seems there's no adult in the room. There's nobody there who takes responsibility. So I did try to advocate and share this knowledge, and in the end, hoping also that people will get more acquainted with these broader effects of vaccines and start requesting the kind of studies that I think the public deserves. So I entered the public space with our findings in 2018, of course, trying to tread very carefully not to create a general vaccine scare, which I don't think is justified. I mean, there are lots of very good vaccines, but and also vaccines I think we have investigated authority and where we can say with a great deal of confidence that they are associated with benefits, like the MMR vaccine, for instance, which is feared by many parents, but where there's actually good documentation both from Africa and from high-income settings that is associated with benefits for the immune system. So I of course, as a medical doctor, I'm also very alert to the possibility that whatever I say about vaccines could create a general fear and a general resistance against vaccines. But this is really not what I'm trying to achieve, but why I try to communicate carefully about it to better educate the public about both benefits and also potential harms of vaccines, so that and that they are not something we should talk about in plural, because they are so different and each come with their own benefits and harms and risk of harm, and that can be very different even for the same vaccine depending on whether you are 8 or 80. So we should really talk much more granular about vaccines. So this has been a message that I advocated prior to COVID, and it came very natural for me also to talk about this when the COVID vaccines came, because my biggest concern was that we would have new vaccines coming to the market that weren't tested properly for their overall health effects, but were given indiscriminatively to all age groups. And there again, with COVID, we had a disease that was so different in in the 8-year-old and the 18-year-old. So the concerns regarding vaccines were so different when we looked at the two age groups. So while I said it was clear that if you were 80 and you had never had COVID before, it seemed like a very good idea to take a new vaccine, even though we didn't have the full picture of this vaccine's effects. Then I saw it completely different from the 8-year-olds. And I felt, again, this was my obligation. It was my responsibility to communicate about that. But I also experienced that there was a very polarized debate, and that became even worse during COVID, I think, where the public domain or the public communication was dominated by two extreme factions that were standing in each their corner. And particularly, I was, there have always been people who were anti-vax, and usually I say, leave them alone. There are a few percent in each country. We don't need to force anybody to take a vaccine they don't want. We should hopefully be able to convince people with good data. And if we can't, then let it be. We could easily eradicate smallpox. We can also easily eradicate measles without forcing those few percent that are completely against vaccines to get them. So I knew they were there, but what I found most appalling during COVID was that the way that most health professionals joined another, the different part of the spectrum, so to speak, and only talk about COVID vaccines as beneficial and efficient and completely safe, etc. They said so many things that nobody could say based on the existing data, and that created mistrust. That creates mistrust because you should, of course, not oversell any pharmaceutical intervention.
Obviously, yeah. It's insane that to this day people don't really see that, even though that at the moment in the Netherlands there's massive attention being paid to mistrust in vaccines, which has apparently grown over the last years. They don't seem to see this part of it, that you have to collect good data. Do you have any final advice to people who maybe want to improve trust in vaccines besides gather good data?
Yeah, I usually say that trust in vaccines are created with good data and transparency. And I think both parts need to be there. We, in the sense of health authorities, need to collect the good data on vaccines' effect on overall health so that it's evident. It should be clear from the data that it's evident for any citizen that it's a good idea to take a vaccine. And if it isn't, then we need to collect some more data. And then we have to communicate honestly about what we know and what we don't know. And both these aspects were missing in the public health authorities' communication about COVID vaccines, and they are still missing. And that is really to the detriment of vaccine trust. Fortunately, I would say in Denmark, we haven't seen declining coverages of the traditional class of vaccines. And we just did a qualitative study that has recently been published where we interviewed parents about their attitude to influenza vaccine, which has now become recommended for children aged 2 to 6 years. And it turns out that parents see differently on the old vaccines and the new vaccines. So they're skeptical about COVID vaccines and influenza vaccines, and they note that it came into their horizon, so to speak, how much politicians were involved in the vaccine recommendations for children regarding COVID and influenza. So they have sort of distrusted these recommendations, but they still trust the old health authorities and their recommendations on the older vaccines. So while we are seeing less than 20% accepting, and that's historical in Denmark, it's less than 20% accepting the new influenza vaccine, we are still way over 90% in coverage with the traditional vaccine.
Oh, no, I think that's a great way to end the conversation. Get the politics out of our vaccine research.
All right. Well, I want to thank you very much for joining us, and thank you very much for taking the time to talk to us, and thank you for the patience and nuance that you've shown in this discussion, because there was a time when I lost a lot of faith in the scientific and vaccine community over the last few years, and it's always great to then see
a couple people who are brave enough to take the risk to speak on this topic, even if it's controversial, even if they know there's going to be a pushback. And that's very inspiring, and definitely helps me keep motivated to stay in the topic. So thank you very much. You have a very nice day and a good holiday.
Thank you. Andrew.
Thank you.